Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled RN Research Using the NSSRN, and it was presented on February 18th, 2021 by Sue Skillman, Hannah Johnson, Cheryl Jones, and Joanne Sheps, along with our guest moderator, Peter Urehouse. My name is David Armstrong, and I'm with the Health Workforce Technical Assistance Center. Today's event is the final webinar in a three-part series on nursing research using the 2018 National Sample Survey of Registered Nurses. And this event focuses on RN research using the NSSRN. And for those of you who missed our previous two webinars, they're available on our website at healthworkforceta.org. So by all means, check them out if you haven't already. All right, our presenters today are Sue Skillman and Hannah Johnson from the University of Washington Center for Health Workforce Studies. And they're joined by Cheryl Jones from the Cecil G. Sheps Center for Health Services Research located at the University of North Carolina at Chapel Hill, and Joanne Sheps from the Health Force Center at the University of California, San Francisco. And once more, we're joined by our guest moderator, Peter Urehouse from the Center for Interdisciplinary Health Workforce Studies located at Montana State University College of Nursing. Oh, that's a bad one on my behalf. College of Nursing. With that said, this event is being recorded, and after today's event, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. Also, you may ask questions today using the Q&A panel on your screen. With that said, we are going to hold off on the Q&A session until after all presentations. So just keep that in mind. But of course, if a question comes to you during one of the presentations, by all means, send it to us and we'll get to it once the Q&A session begins. And I think that's about it for me. So Peter, would you like to go ahead and take over?
All right, David, thank you very much. And David, thanks again for all your work in pulling together this webinar series. And I think it's been outstanding. We've had a lot of useful information and great presenters, and we're going to do that again today. And I just want to say greetings, everyone, from Bozeman, Montana. The temperature here is in the 20s, and we have about 2 feet of snow in the front yard. So everything is in good shape here. I'm really delighted, honestly, to introduce our presenters for today's webinar. I've known 3 of them, Cheryl Jones, Sue Skillman, and Joanne Sheps, for almost my entire career. And I would just say to those of you listening who may not know them, please make it a point to do so, because these 3 people are truly shining stars in health services and nursing workforce research, and I mean that sincerely. So let me begin with some other, the formal introductions. I want to begin with Hannah Johnson. Hannah's going to start us off today. And Hannah's a PhD candidate in the Department of Health Services at the University of Washington. Hannah's research focuses on healthcare delivery and health systems, and she's also a graduate research assistant working with Sue Skillman and our colleague Bianca Frogner, all at the Center for Health Workforce Studies. Sue and Bianca tell me they're thrilled to have Hannah working with them, and I'm just glad to know Hannah's there to keep Sue and Bianca straight. After that, well, and we'll see if Sue joins in or not, but in case she does, I want you all to know that Sue is the Senior Deputy Director at the University of Washington Center for Health Workforce Studies, where she and her team study many different health workforce topics, but importantly, she examines the wide array of all these occupations that we've lumped together under the label allied health. Sue studies ways to improve health equity in health professionals' education and training, and is really quite well known for her studies using the National Sample Survey of Registered Nurses to examine rural workforce changes. Very brief about Sue. After that, we'll move next to Cheryl Jones, who is the professor and director of the Hillman Scholars Program in Nursing Innovation in the School of Nursing at the University of North Carolina in Chapel Hill. Cheryl is also a research fellow at the Cecil Sheps Center for Health Services Research and is a member of the HRSA-funded Health Workforce Research Center, also at the Sheps Center. Many of you know that Cheryl has been a longtime leader in nursing health services research. She's currently using the National Sample Survey of Registered Nurses to model nurse turnover. And throughout her career, Cheryl has studied micro and macro level nurse workforce issues to inform executive practice, improve nurses' work environment, and to understand the role of nurses in delivering high quality and safe care for patients and their families. After Cheryl finishes, we'll conclude the webinar series with Joanne Spetz. And it's a great pleasure, a true great pleasure to introduce my colleague Joanne, who is the director of the Philip R. Lee Institute for Health Policy Studies and is the Brenda and Jaffrey Kang Presidential Chair in Healthcare Finance and is the Associate Director for Research for the Health Force Center at the University of California in San Francisco. Joanne is an honorary fellow in the American Academy of Nursing. She is a foremost thought leader in economic and policy issues involving nurses and the larger workforce. And early in her career, HRSA turned to Joanne to help, for Joanne to oversee the administration of the 2008 National Sample Survey of Registered Nurses. So we have a power-packed group of presenters today. I'm delighted that we're able to do this series. Thank you again, David. So let's get going, and we'll start with Hannah. Hannah, you have the microphone.
Thank you. 1 second, I will share my screen. Okay, hi everyone. I'm Hannah Johnson. I'm a PhD candidate at University of Washington, and I work with Sue Skillman and Bianca Frogner at the Center for Health Workforce Studies. And today I'm happy to present our research on exploring pathways to registered nursing using the 2018 NSSRN. And this study was funded by HRSA. And so registered nurses are the largest occupation in the healthcare workforce and really continue to be in high demand in most healthcare settings. And this will likely be even more so during and after the pandemic. And as with all healthcare careers, we really want to encourage a diverse nursing workforce. Ideally, nursing should be accessible to all who can meet the college admission thresholds. But for some, nursing may not be among career options that they may initially consider. For example, those who are first-time college attendees. But experiences that could expose individuals to or encourage them to consider nursing as a viable career may be especially important. And so one possible pathway to encourage or facilitate becoming a registered nurse includes working in a health-related occupation. And working in the healthcare setting might be a really intentional stepping stone for someone who may already have an interest in becoming an RN, or it may expose individuals who had not previously considered becoming an RN to consider that role. But another key factor influencing whether or not an individual pursues a nursing degree is financial assistance for education. And so while financial support like scholarships or loans can help individuals really overcome some of the cost barriers to enrolling in RN programs, debt from loans can also hinder career progression. So kind of understanding the financing mechanisms is really important to describing RN's career pathways. And so our objective with this study was to compare the career pathways and the use of financial assistance among RNs whose initial RN degree was an associate versus a bachelor's degree in nursing. And so this was a descriptive study, and we used the 2018 NSSRN. We included RNs and APRNs whose RN program was completed in the US and whose first RN degree was either an ADN or a BSN. We focused on question A8 from the survey, which asked about health-related jobs, including nursing aide or nursing assistant, home health aide or assistant, licensed practical or vocational nurse, community health worker, midwife, or other health-related jobs, as well as question A9, which asked about methods of financing for first RN degrees. And that included categories like self-financing, employer tuition reimbursement plans, employer federal, state, or local traineeships and grants and scholarships, federally assisted student loans, other types of student loans, and then as well as some other resources. We also included the race ethnicity variables as they're defined by NSSRN, really to further explore variability in RN pathways. And statistical differences were calculated using the Pearson chi-squared test for independence. There are a couple limitations to our study that we just wanted to note. The first is that the variable that captures prior health-related jobs, it doesn't distinguish between work that was completed prior to versus during an RN degree program. So there could be some RN programs who may require or just encourage students to become a nursing assistant or an LPN while they're in school. And there is somewhat of a limited list of prior health-related jobs. And so of course, we only know of the jobs that are listed. And I just wanted to note that the interpretation of the race ethnicity variables may be limited due to the survey weighting methodology, and that was explored further in the previous webinar. So to dive into some of our results, the 2018 RN workforce had an estimated 1.9 million RNs entering with an ADN and 1.4 million with a BSN degree. And I'm not going to walk through this whole table, but just to note that the distribution of race and ethnicity and gender were similar for ADN and BSN entry RNs. And that more ADN entry RNs currently work in long-term care and home health compared to BSN entry RNs. And so of the prior health-related jobs that NSSRN does ask about, we found that among ADN entry RNs, about 73% held a health-related job before they completed their initial RN degree, compared with 67% of BSN entry RNs. And prior employment as a nursing aide or nursing assistant was the most common for both groups, though there was a statistically significant higher percentage among BSN entry compared to ADN entry RNs. And the second most common prior employment was licensed practical or vocational nurse among ADN entry RNs at 22%, almost 23%, compared to 4% for BSN entry RNs. Shifting gears a bit to look at the financial support of the initial RN degree, nearly a third of ADN entry RNs and a quarter of BSN entry RNs completely self-financed their education. Both ADN and BS entry RNs who held a prior healthcare job were also more likely to have received employer support towards their initial degree compared to RNs who did not have prior health-related jobs. And ADN entry RNs were also more likely to have received employer financial support compared with BSN entry RNs at almost 15% compared to 8%. And they were also less likely to have received government scholarships or grants for their initial RN degree, as well as any federally assisted student loans. When we looked at financial support by race and ethnicity, we found that higher percentages, almost 2/3 of Black, other, and multiracial BSN entry RNs used federally assisted student loans compared with RNs of other races. And that Hispanic ADN entry RNs were more likely than non-Hispanic RNs to have financed their initial RN education with only federal student loans. So in conclusion, there are really similar percentages of ADN and BSN entry RNs who are working as nursing assistants or home health aides before becoming an RN, but prior employment as an LPN or LVN was a much more common step for ADN entry RNs. And then when we looked at financial support, we found that government loans were more widely used than any other types of financial support for RN education, particularly among BSN entry Hispanic or Black RNs. And employer financial support was more likely to be used among ADN entry RNs. There was also no statistically significant difference in financial support by race and ethnicity. So when thinking about some of the implications of our findings, a potential barrier to recruiting RNs and supporting the RN career pathway is really the financial resources that it takes to complete an RN educational program. And our findings suggest that more attention may be needed really to ensure the financial burden is not a barrier to equitable access to initial RN education. though we note that this is probably part of a larger conversation about how we finance higher education in general and may not be specific just to nursing. But we wanted to note that more research is recommended to understand particularly the amount of debt that RNs take on to finance their degree. And future research could explore how debt burden influences RN's professional development. This is particularly important given recommendations to move towards the BSN degree and increased emphasis on the ADN to BSN or RN to ARNP pathways. And I just wanted to take a moment to comment on the NSSRN survey. We know that the NSSRN may be fielded again in late 2022, so we just wanted to offer a few suggestions for the next survey. The first is for the question that asks about prior healthcare jobs, to clarify jobs completed before starting the RN degree, as well as potentially offering broader options for prior healthcare jobs. In addition, considering capturing, when we think about the financing variables, considering capturing the amount of debt accrued both during initial and subsequent RN education. And finally, potentially also capturing relative amounts of different types of financing versus just asking if RNs had any possible finance, had used any of the possible financing options listed. And so with that, I'll conclude. So thank you.
All right, thank you, Hannah.
Yeah.
Cheryl?
Thank you, David, and thank you, Peter. It's great to be here this afternoon. While I'm, hold on, for some reason my slides aren't showing up. Give me just a second. But while I'm troubleshooting these technical issues, let me just say that I'm thrilled to be here today with my colleagues. It's great to see Peter again, and Joanne, it's been a while. And Hannah, it's great to meet you. So I think you should be able to see my slides now. If somebody could just give me a nod, perfect. Thank you. Today, I'm thrilled to be here to talk to you a little bit about we used the National Sample Survey for this analysis in a slightly different way than the others on the call here. We actually use it to verify some work that we're doing, an analysis we're doing here in North Carolina. I'm presenting today on behalf of my colleague, Dr. Asita Patel, who can't be here with us because Asita was hoping to be here today, but she's became a new mother. So we're thrilled for Asita, and I'm sure she'd do a terrific job presenting this information. Just so everybody knows, we all have to give our requisite disclaimers and funding information right from the outset. But I will say that work that I'll talk about today was funded by the North Carolina Board of Nursing, as well as the HRSA Health Workforce Center. And then, of course, the contents and opinions and views that you'll hear today are mine and mine alone and do not represent my employer or any of the other people who have provided funding. I want to start with giving you just a little bit of background. We all know that, hospitals are the largest employer of nurses. And we may not think about it on a daily basis, but hospitals provide nurses with a variety of employment settings. And in particular, there are subsettings within hospitals. And those subsettings have slightly different characteristics. They have different nurse-to-patient ratios, workloads, and nurses also fill different roles in those different subsettings. Workforce analyses tend to, from time to time, need to account for the subsettings separately, which is what leads me to the dilemma we faced in our particular study. Our dilemma was we were in the midst of supply and demand modeling in the state of North Carolina. I want to give a nod to my colleagues at the North Carolina Health Workforce Center. Dr. Erin Frayer is leading this project. And we have a host of terrific folks, including our colleagues from the Board of Nursing who help support this study and provide guidance to us about relevant regulatory issues in the state. But we were in the midst of this supply and demand modeling using North Carolina Board of Nursing licensure data. We realized as we were progressing through the study that the employment setting details gathered during the North Carolina licensure process had changed. Many of you may be familiar with NSSRN. It is the National Licensure Verification Database. And the North Carolina Board of Nursing had changed their licensure questions that they asked nurses to better align with nurses. So the hospital employment setting category had actually been changed so that it combined nurses working in the emergency department and inpatient settings as well as outpatient settings all into one category. Yet because, for the reasons I mentioned earlier, because nurses work in different subsettings within the overall setting of hospital, and because they fill very different roles, we really wanted to tease apart those settings for nursing employment in our projection models. We needed to be able to separate those models as we estimated supply and demand. Like Peter and others on this call, we were especially interested in tracking the shift to ambulatory care. We went, therefore, in search of a solution. Of course, Eureka, we thought of the National Sample Survey of Registered Nurses, but there are some issues we had to deal with in using the National Sample Survey. I mentioned we were using North Carolina Board of Nursing licensure data. We have really, like other states, California and others, a few other states, we have really terrific data in North Carolina, and we consider it to be gold standard data. It contains the full census of nurses in North Carolina. Most of you, because you're familiar with the National Sample Survey, realize that the National Sample Survey gathers survey data from a sample of nurses in each state versus the census of nurses in each state. We needed estimates for a subsample of nurses in a single setting, and our state didn't accurately reflect the nursing workforce in the state. But the National Sample Survey contained sampling weights that could be used in our analysis to estimate the demographic, professional, and educational characteristics of registered nurses in the US. So this was our guiding question. Can the 2018 National Sample Survey data be used to generate state-level estimates around hospital subsettings? And in particular, we were interested in the emergency department, inpatient and outpatient settings in our single state. We wanted to determine the number and percentages of nurses working in the emergency department, inpatient, outpatient settings, nationally and in North Carolina. And we wanted to compare the National Sample Survey estimates to those generated from our data set representing the complete census of North Carolina nurses. In order, we had to take a few steps before we could make those comparisons. From the National Sample Survey in 2018, we had to apply the sampling weights to correct for various sampling issues because of the way data are gathered in the National Sample Survey, because of this complex sampling strategy used. We used the 2008 to 2013 licensure data again, because after 2013, we could not separate the nurses' employment setting due to changes in the Board of Nursing and nurses' data collection. The settings in both cases are identified by nurses' self-report. And we excluded nurse practitioners, nurse midwives, and CRNAs from our analysis because we're really trying to focus on the modeling of RN supply and demand. Here you can see the results of our analysis. And as the slide shows, there were the estimates. The dark blue line represents the 2017-2018 National Sample Survey. The orange line represents the 2017 North Carolina group from the National Sample Survey, the North Carolina subsample from the National Sample Survey. And then the gray line represents our data from North Carolina. And what you can see is the North Carolina estimates from 2008 through 2013 are very similar to the 2017 national NSSRN data. So, and you can see that for the ED, the inpatient, and the outpatient settings. So our takeaway was that the National Sample Survey provides a very good way to actually verify our data in North Carolina. And it also provides a good way to track the shift in nurses' employment settings in states that have an adequate sample. States like California, we happen to be fortunate enough to have an adequate sample in North Carolina. It can be more problematic in smaller states like Peters, Montana, but further analysis of those relationships would be needed in other states to see how well you might be able to the extent to which you might be able to use the National Sample Survey for such an analysis. With that, I'll draw my comments to a close, but I will say just here is some information about how to connect with the Sheps Center and the Health Workforce Center in North Carolina. And here's my contact information if anyone has questions.
Thank you, Cheryl.
All right, I'm up next. I will get my screen shared as well. There we go. So our study is looking at registered nurse diversity and wages in the long-term care industry. Our Health Workforce Research Center focuses on the long-term care workforce, and we have looked at basically everything from home care aides through geriatricians in our studies. It's always fun when we get an opportunity to look at registered nursing and advanced practice nursing because that's where I began my research career. I want to give credit where credit is due. Laura Wagner and Tim Bates have done the lion's share of the work on this, and I think I've got a couple emails related to this project sitting in my inbox that I need to respond to. We are just finishing up the analyses now. RN work settings over time have been fairly stable, and I think we saw this in Cheryl's data from North Carolina. If you look at the American Community Survey over a 15-16 year time period, you have a pretty steady range of the percent of nurses that report they're in the hospital industry, although their roles within hospitals might be changing. Similarly for physician offices and for nursing homes and residential care. From the National Sample Survey in 2018, which uses somewhat different industry categories, we saw in the data that about 6% said they were in home health or hospice, and about 4.4% said they were in long-term care or nursing home environments. So for these nurses that are in these long-term care environments, there's a number of different things we've seen in the data. They tend to be older. From the literature and from the National Sample Survey, they tend to earn less than they do in other settings if they're in long-term care. They are also less likely to have a bachelor's or a higher degree. They're more likely to be internationally educated, and they are more likely to be Black or Asian, but less likely Hispanic. And in states where we have data about Asian subgroups, predominantly it's Filipino that they're more likely to be as opposed to other Asian subgroups. So we wanted to know and take a look at some of the racial ethnic differences of wages. And in the broader literature, there was a really important paper from David's colleague at University at Albany, Jean Moore, and her colleague that looked at Black and Hispanic registered nurses in urban hospitals and found that they earned less than white and Asian registered nurses. We know also that long-term care registered nurses earn less than hospital nurses. And we wondered if the higher proportion of particularly Black nurses in the long-term care setting could be a contributing factor to that wage difference in long-term care. So is that race ethnicity really the explanation for the lower wages? Also, immigrant status could be another factor. If there are lower wages offered to immigrants, that could play into long-term care. And what other factors are affecting the lower wages in long-term care? So we use the National Sample Survey of Registered Nurses, as everybody else here has. We focused on employed nurses who were not in advanced practice, and we calculated the hourly wage as earnings divided by annual hours. And we excluded anybody where their calculated wage was lower than the minimum wage. We figured that was probably reporting error, or could be that somebody is doing largely volunteer work but receiving a small stipend, and then they reported it and it just looks weird in the data. So when we did those relatively few exclusions, the full population we had was over 14,000 nurses in the data set. And we looked at some cross tabulations, and then we also estimated wage regressions. The classic labor economic way to put these together is to have log wages as the dependent variable, because wages tend to be skewed for most occupations in the US, where there is a kind of bunching around a median area, but there's a long tail of higher earnings. So doing the logarithm kind of makes that distribution look a little more normal. Our control variables include census regions. We tested also with state dummy variables, same result. Experience in a quadratic form, an indicator for full-time employment, prior LVN employment, which reflects back on that first paper by Hannah, union representation, international education, gender, education level, highest education level, current enrollment in school, marital status, and presence of children. These last two variables, in theory, should not directly affect your wage, right? Like your employer should not be paying you differently because you're married or not married. But what we do know from the data is that when we measure experiences, the years since you graduated, people who are married and people who have children in the home tend to work fewer hours over their careers than people who are unmarried and people who have not had children. So this is a way of accounting for differences in experience that are not measured well by that experience variable. We tested, for those of you who are really nerdy, we tested what's called a Heckman correction for selection into employment, which could bias your results, and the results were the same. So you can not worry about that. So what are the characteristics of our employed nurses? So this describes their race, ethnicity, and their age groups, and there are a few differences that are particularly notable. One is that non-long-term care jobs had a higher proportion of Hispanic nurses. Blacks were somewhat more represented in the long-term care setting, and Asians as well, but not as big a differential. Long-term care does not have as high a percentage by a long shot as younger registered nurses, and has a higher proportion of older registered nurses. So you've got differences in the ages and in the race ethnicity between these two sectors. We also looked at the education differences, and associate degree nurses are more represented in the long-term care workforce than in non-long-term care. And consistent with some of Hannah's work, people who previously worked as licensed practical nurses or licensed vocational nurses were more likely to be in long-term care. So I think this is really interesting in the context of knowing that people who previously worked as LPNs are also more likely to be associate degree educated. Let's see, so we also then looked at the characteristics by race ethnicity. And the big differences that we found there were related to the younger age. The younger age group had more Hispanic nurses and fewer Black nurses than the older age groups. And for the older age group, conversely, many fewer Hispanic nurses, but a higher proportion of white nurses. For education, note that almost 80% are bachelor's educated for Asian nurses. That may be in part because of the relatively high proportion of Asian nurses that are immigrants. Many of those are from the Philippines, and in the Philippines, the bachelor's degree is the standard education of those who migrate to the United States. So that high percentage Asian bachelors may be largely described by Filipino immigrant nurses. Okay, what about their employment characteristics? Just a few other things so we have the lay of the land. One thing to note is that union representation is much less common in the long-term care industry, and about 20% of nurses in other settings are union represented. That varies a lot across states too. You've got not much of a difference in the percent of nurses that hold more than one job between the sectors, but you have a much higher turnover rate of people in the long-term care industry than nurses in non-long-term care jobs. So what happens when we do our wage regression? Oh no, sorry, this is the median hourly wages. And the patterns here are pretty consistent. Long-term care nurses basically earn less straight across the board than non-long-term care at the median. Go back to that. Unionized nurses earn more than non-unionized nurses. And there are the differentials between race ethnicity are pretty consistent between the long-term care and the non-long-term care. And the people in long-term care have lower non-nursing household income. So now we're at the regression results. So lots of things going on here. I'm just going to highlight a few things that are really interesting. The first thing to note is that for all RNs, unlike the paper by Moore, we found that Black nurses had higher earnings than other nurses. I think white is the reference group in this analysis. And Asian nurses among all nurses also had higher earnings, including in long-term care. So the differential for Black nurses did not persist in the long-term care setting, but it did for non-long-term care jobs. But for Asian, it was straight across the board that Asian nurses had higher wages. Nurses educated internationally had no difference in their wages once you controlled for all the other factors. The education level made a difference. But again, for all nurses, that shows up as statistically significant, that you earn more with a bachelor's or graduate degree, but that does not persist if you focus only on long-term care registered nurses. It is a non-long-term care phenomenon. Experience also in long-term care has really not much of an effect on your earnings compared to other settings. Previously, working as an LPN is associated with lower earnings, except again, that does not hold up in the long-term care setting. And unionization has a relatively small effect and arguably not statistically significant effect within the long-term care setting, but it has an important significant effect in non-long-term care. So what are we concluding from this? Well, first, the lower wages in long-term care do not appear to be the result of race, ethnicity, or international education differences. The main causes of the lower wages honestly appear to be that long-term care does not reward education, it does not reward experience, and it does not really reward unionization at the same rate as non-long-term care nurses. So essentially, if you're a registered nurse and you work in another setting, you get higher wages for all of these factors, and in long-term care, you will not. Now, we have a number of limitations we have to deal with. One is that this data does not include a rural-urban indicator in the public use data file. If you want the rural-urban indicator, you need to go through an application process to access the confidential data, and I've only filled out half of that application so far because it's really long. So we do know that minority nurses are more likely to work in urban areas, and those areas may have higher wages, which was the reason that the Moore paper limited to urban hospitals in their analysis, and this could confound our results. The other factor that we're concerned about is that the data don't include job titles. And from other analyses, we know that there is a higher, we know that Asian long-term care nurses are more likely to be the director of nursing in a nursing home. So without having this job title, it's really hard for us to ascertain whether the higher wage for Asian long-term care registered nurses might be because they're in management jobs. And then, of course, we have the normal limits of a sample survey, response bias, self-report, et cetera. You know, we know those issues. So we have a few implications. One is, of course, we know that long-term care wages are lower than other settings. This is even though the workers have more experience. And that may be a reason that there is more turnover in long-term care, that even with all the experience nurses have, they do not get rewarded for it. The long-term care settings really should be thinking about rewarding education and experience. We know that quality of care is linked to these factors, and that nurses leave jobs when they do not feel rewarded or they lack opportunity for growth. We also think that management and leadership opportunities may play a role in that recruitment and retention, but until we have that job title variable, we don't know the answer. And finally, long-term care employers appear to pay minority RNs fairly equally badly, and that we need to examine these racial and ethnic differences in more depth, including urban and rural differences, in order to fully understand the patterns. So here's my email if anybody would like to contact me, and happy to take questions.
All right, thank you, Joe. And thank you, Cheryl, and thank you, Hannah. Those were all great presentations. With that said, just a reminder to those of you in the audience, you may ask questions using the Q&A panel on your screen. With that said, Peter, would you like to start us off?
Yeah, thanks, David, and thank you, everyone, again. And I just two quick questions and a comment. For Hannah, I'm wondering, work like yours has been done in the past. Yours is slightly different than what others have done, and I'm curious if you can reflect on what is new and what are the important insights that you've gained from your study compared to others. And second, I wanted to just comment on Cheryl's paper that I'm really glad you did this work, because I think we're missing a lot of opportunities to use these data sets to confirm findings or estimates when we look to compare that to particularly like the ACS, which what Joanne was talking about. So I'm glad you did that, and I think we have more to work, more can be done with that as well. And then Joanne, the one question I had for you is, I don't think you mentioned in your findings whether there was a male-female difference in earnings. So if you'll ponder that while we go back up to Hannah and just say, Hannah, can you just sort of respond to that question about how your findings are different and add to what others have done?
Yeah, and I think actually I may defer here to Sue as well, because she has a much kind of broader depth of experience with this work as well. So Sue, I don't know if you have anything you'd like to add in.
I'm pondering that. Of course, you know, the 2018 data are among some of the more recent data to look at this. What Hannah didn't go into, and what will show up in some of our in our reporting, is we actually looked at cohorts over time, or graduation cohorts, you know, to look at if this changes in financial support and prior jobs look different and different cohorts and things. So we didn't get into that. There are some differences there, but I think we confirm some of the findings from other studies around the not as much racial ethnic differences as some might hypothesize. But I think that goes back to the fact that once you get into nursing school, there's similar racial ethnic distribution in both the ADN entry and the BSN entry careers, which merits, I think, more research around you know, what it takes to get into nursing school at whichever level, and maybe if there's any bias going on, it's prior to getting into nursing school rather than you know, sort of what happens afterwards. But that's all worth more work.
One thing I will add too is I think that you know, when we're thinking about how nurses are financing their education, I think this study opened up for us at least a lot of conversations around thinking about And this study just kind of opened the door to this, but thinking about the impact of debt burden and what that's going to mean for decisions that nurses make in the future with their career pathways. And so that has also definitely been an area where we'd like to pursue, to understand really what the debt burden impacts are in future studies. And also just to understand what financing mechanisms nurses are using to finance their degrees, and kind of what combinations of financing nurses are using, I think is an important contribution. And we didn't see much literature on that when we were looking.
Thanks.
All right, you asked about gender. I had to pull up the output because I did not include that in the slides because they were already getting too busy. But we did find a gender differential for all nurses, as is consistent in the literature, with men earning more than women. That did not appear in the long-term care setting data. It was non-long-term care. And one comment that I spotted in the chat was around that some of the coefficients for long-term care were pretty similar to the non-long-term care, but the sample is smaller, so maybe that explains the lack of statistical significance. But we did have over 1,900 nurses in the long-term care regressions, which you would think is enough power to detect a lot of differentials. For gender, though, the coefficient is 1/7 the size of the coefficient for all nurses. So for gender, I think that really goes away in the long-term care setting.
Thanks, Joanne.
Okay. We do have a few questions from the audience. Are we ready to jump in? All right, great. First is kind of a general question. I believe anyone on our panel can take a shot at answering. I think it's really kind of a two-part answer, actually. But can one of the panelists discuss the process of obtaining the NSSRN data for research?
I can explain it to some degree. So there is a public use data file. So you can download that. It's free, easy to get. It's a pretty clean data set. The first chapter or part of my dissertation I did in graduate school was using the old NSSRN from years I won't even admit to right now. It's a super clean data set, great for research. To get the non-public version of it, it is viewed as a restricted data set because of concern about releasing individual level information that might be viewed as sensitive or confidential. So to do that, you have an application process through the Census Bureau. That includes writing a research protocol that explains what you plan to study, including ideally examples of the kinds of tables you expect to produce from your analysis and what variables you will use. You provide information about all the variables you would want and a justification of those, and then you submit your application. Once your application is approved, you then need to become basically you need to get special sworn status of the Census Bureau. So you have to literally swear before a notary that you will not do anything bad with the data, you won't release it, you will abide by all the rules, etc. There is a security clearance process. And then to analyze the data, for most of the data sets under this category, you physically have to go to a Census Bureau affiliated research data center and analyze the data in person. So I'm in the process, I already had special sworn status from another study, and I'm in the process of putting together an application so I can go over to Berkeley. Most of the RDCs, though, those data centers have been shut down this year because pandemic. So the fact that I haven't filled out my application isn't really that big a deal because I couldn't go there anyway.
All right, thank you, Joanne. Actually, there's a couple more questions, and I believe they're both for you. Well, you're popular today. Are there data to indicate the financial status of the facilities, that is hospitals versus long-term care facilities, in which nurses work? It seems that salary is largely influenced by the financial situation of the facility. which also speaks to the broader community, such as, rural versus urban?
Great question. That is not available in the National Sample Survey, even in the restricted use data. They just don't ask nurses to report whether their nursing home is for-profit or not for-profit. I think you could use CMS data to look at that, especially with the payroll data systems that are now available from CMS as part of the Casper system.
Okay, thank you. One more question for you. And there isn't a question on job title in the survey, but there is a question of B15 on time use broken into 7 categories, including management, supervision, and administrative tasks. Did you consider using this?
We have, and that is something that we might chase down. The challenge is that for registered nurses within the nursing home, they often are much more involved in the assessment of patients, developing care plans, supervising the other personnel and such. So it can be very hard to distinguish in terms of those tasks, what the line would be between a registered nurse doing normal long-term care nursing home type duties versus the registered nurse who's formally in a director of nursing title. It's a little bit subtle. But we may look at that and see if we can get any new information from that.
Okay, thank you. Oh, what's more? One more question. Just a second. All right. Well, I'll just ask it. Joanne, once more, this is for you. How does age and retirement status affect your results? From discussing with some RNs in long-term care settings in Virginia, one of the things revealed was that it provided more flexible hours, and several of those I spoke with were retired from their main jobs, had benefits from their spouse's jobs, and therefore were just looking for a flexible job post-retirement. Do you have any insight into this?
That is a great observation. I don't think that the National Sample Survey would make it easy to identify that. That might be something I could do with the California Board of Registered Nursing Surveys because we have a little more detail. And it is consistent with what we hear about any number of different nursing positions where, the economist term would be the compensating wage differential. And some people are willing to take a lower pay level in order to have more control over their hours or to be able to work part-time more readily or to be in an environment that they just perceive as a more desirable setting. If you really like working with older people, but it doesn't pay well, you might save that for later in your career. You're done paying your kids' college tuition bills. Now you can afford to go pursue your passion. So there may be some population of nurses who kind of retire from their career job and then pursue long-term care work because they love it or because it's more flexible or these other factors. But we don't have a lot of data on that. So I'm really glad that there's interview-oriented research to help chase that down, because I think that's really how you got to get at those questions.
Okay, thank you. And we actually have another question, which is really to all panelists that came in through the chat. Is there a data source where you could evaluate employer needs for nurses or other health workers?
Nationally, you could look at the current population or the Bureau of Labor Statistics, occupational employment statistics, where they project the future employment and use that as a starting point. And then HRSA has their own supply and demand forecast for multiple different professions that you could look at. Some states, but not all states, do surveys of employers about their planned employment. And University of Washington, well, I'll let Sue Skillman talk about their Sentinel system, because that I think is one of the more innovative ways of trying to get that data.
Sure. Yeah, I was going to mention that. So in Washington State since 2016, we've had the Health Workforce Sentinel Network that collects qualitative information basically from healthcare employers about their health workforce needs. And if you look on our website, wa.sentinelnetwork.org, you can see summaries that show that in long-term care settings, for example, nursing assistants, RNs, and LPNs have been the jobs, the occupations that have been consistently listed most frequently as being difficult to occupations where vacancies are difficult to fill throughout. So they're in demand. We've got those data clearly in Washington. I mean, you can look at it quantitatively, but through the Sentinel network, we've got the descriptive information on why the employers think there are problems. They're not saying as often, well, they are saying low wages in comparison to hospitals. Definitely, they're speaking to that. Connecticut implemented 2-round data collection with the Sentinel network, and I know Marcia Proto's on this, and we are talking with some other states about implementing the Health Workforce Sentinel network as well. So it is one way that at a state level, you can get that kind of validation that recruitment and retention is difficult in some of these settings for nurses.
All right, thanks, Sue. And we're right at the top of the hour, so maybe we should move towards wrapping things up. With that said, could each of you maybe share one take-home point from your presentation? I mean, if you had to say, okay, what's one item from the presentation I gave that you would like people to remember? Like a closing thought, if you will.
I'll say from a broad standpoint that long-term care jobs don't pay well, but if you look at the importance of those jobs, they should pay more, and they should be rewarding experience and education more.
Very good point.
And I'll jump in and say the National Sample Survey can be used to verify certain observations that you may want to ensure that have correct information on in your state. But also in the case of nurses and the nurses change, I think that one's probably given everybody on this call a bit of a headache at one time or another. And I would just say this, to me, represents an opportunity to, it's almost like the NSSRN is a cross-check on the data that we have, either that we're gathering in states or that we have coming to us from nurses. So I would like to think that NSSRN provides a great way for us to uncover some of the issues that may get blurred through other data and data sources, but also to help change policy, because if there's a way we can elevate these issues to areas of concern at higher levels, I think that will be really important use of these data.
Fantastic.
And I think I'll just say that we just want to make sure that, ideally that, financial burden is not a barrier to equitable access to RN education as we move forward.
Thanks, Hannah.
Yes, I agree.
And thank you, Sue. Well, Peter, I think we've come to the end of our webinar series. Do you have any closing thoughts you'd like to share with the audience?
I would just say that once again, this survey just keeps giving with opportunities to research. And in my whole career, I've never learned more about nursing than any other source but the National Sample Survey. So I am glad it is back. I'm excited that it will continue, given our world of COVID and other changes going on in society. It's going to be even increasingly important going forward. And so I'm just happy that we're having this webinar to kind of, welcome back Sample Survey. We've missed you, and we're looking forward to learning more about our profession in the future as well.
Thank you, Peter. And thank you, Cheryl, Hannah, Sue, Joe. And of course, thank you in the audience for attending our events. We greatly appreciate it. And like Peter said, the NSSRN is a great resource for the community, and we hope it continues in the future. With that said, have a happy afternoon. Take care.
Thanks, David.
Bye-bye.
Thanks, everyone.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.